Now it's the time. We've changed the turn, but now it is the time of Dr. Bruce Allen, an amazing corneal surgeon from Moorfields. Thank you, Bruce.
Great, thank you very much. I'm so sorry about the timetabling disruption here. So I'm going to, when the talk comes up on the screen, follow Harminder with some interesting use cases for endothelial keratoplasty. So rather than talking about DMEC technique generally, we're going to just talk about some use cases for endothelial keratoplasty which have found a place in our practice and may be useful for yours too. So we're going to start out with macro perforations. So the conventional approach to a macro perforation surgically is to do a lamellar dissection. Is there a pointer here? Is there some kind of, or can I point with the mouse?
It will work anyway.
Oh, there we are. Okay. So you normally have to take your lamellar bed down to a depth that's deep enough to take a full thickness piece of donor tissue, which is hard work, and then you have to put the cornea over the top of it, map out the size of the defect by dotting through the cornea there, mount the cornea on an artificial anterior chamber, cut that out, sew it in. That's 2.5 hours work quite often, and you end up with quite a lot of irregular astigmatism. So we were looking for a better way in these kind of, particularly the quiet post-glue medically treated perforations. So I'm just going to stop this video here because we seem to have jumped forwards. And so we were looking for a way of dealing with this without such a laborious surgical approach. So we were thinking of using endothelial keratoplasty as a plug to plug ab interno. And this is a video that my colleague Alfonso Vasquez Perez, a super surgeon who was working with me as a fellow at the time, has put together, and he's taken this forward really nicely. So we mark the DSEC donor out. Here we are in the wet lab, trying out different bursting pressures with different sizes of experimental perforation. You can move this little patch quite easily with a needle over Provisc in the chamber there. And how do we do with a bigger perforation? Look what happens here, and it herniates through. So what are we going to do about that? Well, a mattress suture works really well to give it that extra support that it needs. And then you can close even quite a large perforation with a DMEC patch posteriorly. It's quite an easy thing to do technically on the table, and well worth trying in advance of doing a conventional banana graft or something like that, particularly for an off-axis perforation. So here's the first case we tried it in. It's just off-axis, this perforation. And rather than doing just a straightforward PK through the center, he had a normal endothelium, normal cornea elsewhere. We tried the patch, and you can see there, once we got air introduced, the air tamponades it in place. We can then layer up with fibrin glue and amniotic membrane, and finishing off with basement membrane side down, amniotic membrane there, just to encourage epithelialization and removing the viscoelastic and the air through the side there. And there it is 3 days later, and here it is, I think that's 6 weeks down the track. And the encouraging thing is this patient is 6'6" unaided, unlike a PK, for example. It's rather a thick posterior donor there, posterior plug. So we then went down to a thinner plug, and this is a case of a peripheral melt. And that's freeing up the iris adhesions there, and then preparing the donor. And we usually go about 1 millimeter larger than the perforation all round, and then pushing this donor through the perforation there. That's Alfonso's rather nice variation, and a bit of air in the chamber, and then some fibrin glue and some amniotic membrane to layer up there, and then a bit of amniotic membrane over the top, basement membrane down to finish off to encourage epithelialization. And again, in a eye like this, I think this might have been a Stevens-Johnson case, not a good prospect for a penetrating graft at all. You're just seeking to preserve globe integrity. Then it's a really nice variation. I'll skip this on a bit because I want to show you the mattress suture in the third case we've got. I think that we've got that here. There we are, thinner graft. And I think I can fast forward here. I'm going to try. I can't. Okay. So here's a larger perforation, but you can see the mattress suture going in over there. And that stops the donor just herniating straight back through the perforation when you put the air bubble in the chamber. So I'll leave it there because I want to move on and show you a couple of other things. But that's a nice variation on doing a large tectonic graft in cases where either you're not seeking to preserve vision, you're just trying to preserve globe integrity, or an off-axis perforation in an otherwise fairly normal cornea like the first case we saw. Something that's going to go well in tandem with that, I think, is newer regenerative bioglues, and this is a collaboration with May Griffith in Montreal. We've had some really promising results in mini pigs. You see normal cornea along the top pane here, and the lamellar defect that's been filled with a gel, a bit like using a dental filler, and then you get cellular regeneration into that framework and nerve regeneration as well, and a normal epithelium too. That's not too far away from clinical trials now, I hope. So how about another use case? This is posterior stromal opacity. Remember, the original iteration of endothelial keratoplasty was DLEC, where we removed the posterior stroma as well as the donor. So you can use the femtosecond laser to make a nice ring cut there, and that deals with the most technically difficult part of that operation. Femtosecond lasers don't work well in the posterior stroma for a lamellar cut, by the way. They don't produce a regular or a good clean cut. So do a lamellar dissection first, take the patient upstairs to the femtosecond laser, do the ring cut, and then it's a beautifully easy operation technically to do a DLEC. And so here's the side, a compare and contrast for that rather unusual copper deposition syndrome there, hypergammaglobulinemia. Here's the cornea before the surgery. On the left, you've got what happened when we did a DSEC, and with that thought, well, there's an improvement. We can just see the pupil here, but it's not as clear as we would like. But look at the difference when we did a DLEC there in the other eye. So a nice variation. Also useful if you get a bad posterior lamella with a lamellar graft. You can do the ring cut with the excimer laser, peel out the scarred posterior lamella, and drop in a little DMEC or a DSEC there, and that works really well. How about the last little corner that I want to show you, that if you may have a case like this that's aphakic, a unicameral eye, and you want to do a DMEC because it's a bit easier in terms of avoidance of rejection than a DSEC and a safety net suture. So that's, we don't want to drop it in the back of the eye. And so this safety net suture technique here is a nice variation. We'll show you that just now. The main thing to say about that is it has to be an odd number of passes backwards and forwards across the anterior chamber to create this safety net. Otherwise, you don't finish up where you started. And that's with a straight tenoproline there, back and forth, an odd number of passes in both directions, and then you should finish where you started. We've learned that it's best if you don't make your incisions until after you've done this, just a very small incision to keep filling the chamber through, and leave the other incisions until afterwards. This is very difficult in the soft eye. And so we're going backwards and forwards there across the chamber to create that safety net pattern. And finishing up where we started. And this creates a really nice, shallow, pseudo anterior chamber, and makes it very easy to unfold the donor subsequently. And again, it's a technique that looks more technically difficult than it really is. A nice variation, if you get a deeper set eye, is to bend the needle. And that was something that was described by Samuel Maskett when he talked about using a similar technique to support intraocular lenses during surgery. And so we should finish up with this last pass, which you're going to see at the moment, just where we started, ready to tie it off. And then you have your safety net, and you're ready to make your incisions. How are we doing for time? We must be almost over, yeah? 2 minutes more. Oh, okay, better than I thought. All right, so we're just going to finish off where we started and tie off. And as I say, what we learned is that if we do this after we've made, before we've made our incisions, it's much easier. You don't have the eye softening all the time with leakage through the incisions when you're passing the sutures. So we just do one small one, this little one on the side to fill up the eye to a firm pressure, and it's quick and easy to do that with a Simcoe, by the way, or you can use an AC maintainer if you want to. And then your incisions, just make sure you stay anterior to your safety net and try not to cut the suture. Easy enough to do though. And then you have to do the rhexis over air in a unicameral eye. And you can see the suture pretty clearly there. And so the rhexis is done over air. Always difficult to contain the air bubble in the AC, so again you can use an AC maintainer and air infusion if you want to. But this is much easier than we thought it was going to be. Once you have the graft laid out, just inject slowly. And then the chamber is shallowed by the suture, and it's quite easy to open up the graft. And there you can just follow with a little mini bubble underneath that, and use the little sweeps with the Simcoe just to center the graft over the mini bubble. That's a technique that Frank Price showed me. Really nice addition to your EK technique if you're not already using that. And then fill up to a good pressure with the eye of the fluid, then you tend to get the bubble behaving better in the chamber when you inject it if you fill the eye up to a pressure first. And then it's easy to remove this suture. And most DMEC detachments are partial, even if you get a detachment, so you can remove the suture at the operation. You don't have to leave it in, but you can if you want to. And so there's a case, and there are a few more. But I've just come from an innovation session on cell therapies in endothelial keratoplasty, and this is great. I mean, you can all do this now. It's one of these things you can just see the video and you can do it right away. But I don't think we're going to be doing this for very long in these kind of eyes, because what looks really good to me is cell therapy without passage. We were talking about this last night, weren't we, Nicholas? And I think that's going to be the way to go, is just taking a cornea, taking the cells from it, injecting them, posturing the patient. And in these kind of technically difficult cases, like the unicameral eyes, the eyes with an irregular posterior surface, I think it's going to change everything. So for now, though, this is useful. Thanks. So I'll leave it there. Oh, last word, though. I want to advertise our little session in Prague. So if you have a free spot in your summer, I really hope you're going to join Harminder and Nicholas and Jesper and Frank and all of us over in Prague for a nice meeting there. Bye. Bye.